Hello my dear friends. Today we are dealing with an important topic in pediatric dentistry, that is pit and fissure sealants. Here you can see before sealants and after sealants picture. We will be dealing with pit and fissure sealants today. Pit and fissure sealants, the prevalence of dental caries has been decreased nowadays because of water fluoridation, improved oral hygiene and use of dentifrice. But greater efforts are being made for the reduction of smooth surface caries rather than the pit and fissure caries. And we need to know that the pit and the fissure areas are more susceptible to decay than the smooth surface caries. Pit and fissure sealant application will prevent it by acting as a physical barrier that inhibits the bacteria from attaching to the tooth where there is a pit and fissures on the tooth. So, pit and fissure sealant is a material that is placed on the pit and the fissures of the teeth in order to prevent or arrest the development of dental caries on the tooth. You can see a tooth with the pit and fissure sealant is more prone to decay than the one with the fissure sealant, which prevents decay and protects the tooth. Types of pit and fissures. According to Nagano in 1961, he classified the pit and fissures as U-type, V-type, I-type, IK-type and the inverted Y-type. Types of pit and fissure sealants. They are broadly classified into three main categories like the resin-based sealants, the glass ionomer sealant materials and the polyacid modified sealants. So we can see various types of pit and fissure sealants which I have discussed now. So resin-based sealants, they are further classified based on the polymerization, viscosity and translucency. Based on the polymerization, they are classified into fourth generation. The first generation is UV light polymerizing pit and fissure sealants. The second is chemically cured or autopolymerizing. The third one is a visible light polymerizing. And the fourth one is a resin-based fluoride releasing sealants. Based on the viscosity, they can be classified as filled, higher wear resistance and unfilled, lower wear resistance. Based on translucency, opaque and transparent. Glass ionomer sealants are usually moisture friendly compared to resin-based sealants. The transitional sealants can be used in partially erupted teeth. Their fluoride releasing property and also fluoride recharging property is also present. Polyacid modified sealants, they are referred to as compomer, combined traditional visible light polymerizing resin with glass ionomer with fluoride releasing properties, less water soluble compared to glass ionomer sealants and less technique sensitive compared to resin based sealants. Ideal requirements of an efficient sealants. They should have good viscosity, adequate working time, rapid cure, prolonged adhesion to the enamel, low solubility, resistance to wear, minimal irritation to the tissue and definitely karyostatic action. Contraindications of these pit and fissure sealants. If you have a wide self-cleansing pit and fissures, radiographic evidence of interproximal caries, the tooth cannot be isolated, life expectancy of the tooth is limited and occlusally you can see that the tooth is carious. Clinical technique for the placement of pit and fissure sealants. You need a tray, you need to clean the tooth surface, isolation, acid etching, rinse and dry the tooth surface, apply the bonding agent, apply the sealant. Curing of the sealants needs to be done. Evaluation of the sealant is necessary and at last re-evaluation is very necessary. So these are the various procedures. Some people also use stage selection for the sealant. Now a tray setup. A tray needs to have a lot of things like mouth mirror, handpiece, explorer, applicator brush, sealant material, cotton, saliva ejector, curing light and articulating paper. Cleaning of the tooth surface to remove any plaque or debris prior to sealant placement. You can use a pumice, prophylactic cup or a bristleware brush. Some aggressive methods can also be used but not recommended. Some manufacturers recommend application of the fluoride before placement of the sealant. Isolation is the most critical factor. Salivary or moisture contamination will decrease the bond strength. Rubber dams, cotton roll or a new system that is called the isolite system is now being used for isolation. Acid etching, 35 to 37% phosphoric acid is used for acid etching. Etching time has been reduced from 60 seconds to 15 or 20 seconds. Earlier, primary tooth etching time was double that of the permanent tooth because they had got a lot of aprismatic enamel. Now, the etched tooth has to have a chalky white appearance. Etching will remove any organic panicle or aprismatic enamel, and a micro retentive pattern will be formed which will help the resin to infiltrate into the tooth. So, rinse and dry the etched tooth surface for 30 seconds. Rinse the tooth surface for 30 seconds, then dry the tooth for 15 seconds. It should have a white frosted appearance. If salivary contamination occurs, you have to re-etch and repeat the procedure. Re-etching time is 10 seconds. Acid etching and the rinsed tooth should have something called as a white frosted surface or appearance. Application of the sealant. Minimum of the sealant must be applied to the susceptible pit and fissure. It can be applied using an explorer, small brush, dispenser, preloaded syringe. In mandibular teeth, apply sealant distally, allow it to flow mesially, while in the maxillary arch it is the opposite, apply mesially and allow it to flow distally. Allow the sealant to flow into the pit and the fissures to prevent incorporating of the air or creating voids. Use a fine brush or applicator possible in cuspal inclines and secondary fissures. Curing is done with the curing tip placed as close as possible to the tooth structure and the time recommended by the manufacturer. Evaluation of the sealant after polymerization before removing the isolation. Examination, visual and tactile of the sealant has to be done. Check for any void, air bubble. Retention should be evaluated with the probe trying to dislodge the sealant. If the sealant is dislodged, re-etch the tooth and reapply new sealant. Excess sealant from the margin should be removed. Any occlusal adjustments has to be done. A small discrepancy in case of unfilled sealant can be easily tolerated, but filled sealants you have to do occlusal adjustment with an articulated paper or something to avoid discomfort. Recall and re-evaluation done during the routine recall examination. If the sealant is lost, reapply the sealant. If the sealant is partially lost, try to dislodge it with a probe. If it doesn't come out, we need to apply the sealant where it is lost. Single application of resin fissure sealant has been found to be beneficial. So, a sealant tooth is a hard tooth that is resistant to decay, and only have a recall visit with the dentist in case the sealant is lost. If sealant is placed, your tooth is definitely protected. Thank you one and all. I hope you like this topic. Now recommend me or suggest me for new topics which you would want me to discuss in the comments below. Thank you one and all.